Welcome to Better Than Ever Live, wherever you're watching or wherever you're listening. Hope you're making today your masterpiece. It feels weird. I haven't been doing this show in over a month. I'm so excited to be back. On today's show, we're going to talk about steroid injections, namely cortisone shots, and doing those for knee arthritis. Even though these are the most common treatments offered by orthopedic surgeons for arthritis of the knee and osteoarthritis, short of a knee replacement, we're going to discuss a study showing why they have much worse long-term harms for you and your knee than they do short-term benefits. My name's Dr. David Geier, triple board certified orthopedic surgeon, sports medicine specialist, anti-aging and regenerative medicine expert, and media medical expert as well. I hope you feel and perform your best regardless of age, injury, or medical history. As always, in today's show, in this live stream, I'm not giving you medical advice. This is meant for general information and educational purposes only. If you have thoughts, comments, questions about cortisone shots and knee arthritis, leave those in the chat, not in the comments. I can't see them in the comments to those of you on YouTube. Only in the chat, Facebook, LinkedIn, leave those where you normally do. I'd love for you to give your name and where you're located, not the user handle that I don't know what that means, but first name wherever you're located. I would love that along with your comment and question. If you have medical questions, orthopedic questions unrelated to steroid shots and arthritis, join us tomorrow and pretty much every Friday for Ask Dr. Geier Live. Very, very excited to be back. And Angela is coming to us from Melbourne, Australia. Good morning to you. It's our late afternoon, but very good morning to you, Angela. Very glad to see you. It is really good to be back. I've taken, I guess, this hiatus has gone on about a month now. I was finishing my studying and my work for my third board certification in anti-aging and regenerative medicine, which, as you heard in my introduction and I talked about on Ask Dr. Geier Live last week, I obtained finally just over a week ago. I passed the written exam in June, passed the oral exam, which was brutal in September. I actually thought I had failed when I took it. It was terrible, but I did pass it. All that stuff, hormones and GI stuff and cardiology and neurology, things that I haven't done since medical school. I've been doing orthopedic surgery, so I had to learn all this new stuff. But it's great because now that I've got all that knowledge, I've got that board certification, I'm really, really excited because it sets me apart from other orthopedic surgeons, pretty much all orthopedic surgeons that approach everything as, hey, let's do surgery right away, first line treatment, or cortisone shots. Now I've got this huge world of possible treatments I can discuss with my patients to help you return to what you love to do. And if you're interested in some of those treatments, or maybe seeing me specifically, me in person, for an injury or pain, I'll discuss how you can do that at the end of the show. But going forward, I'm going to do this live show a little different. Better Than Ever Live will be a little bit different. I'm now going to focus on just one topic per show, usually one study per topic and per episode. I'm going to give you insight into this world of what I call anti-aging orthopedics. We're going to talk about why a lot of the traditional orthopedic treatments just aren't right for a lot of people. We'll discuss modalities like hyperbaric oxygen, shockwave treatments. We might talk PRP, stem cells, exosomes, medications like penisin polysulfate, metformin, rapamycin, melatonin, maybe some supplements that can protect cartilage, bone, muscle, tendon, ligaments. We'll talk about the rationale behind peptides like BPC 157, thymosin beta 4, CJC with ipamorelin, many, many other topics like that. Things like diet, arthritis, how diet affects your arthritis, exercise changes to help you get your injury to heal, how to avoid injury in the first place, so much more. I'm going to really, really focus on making it research-based, finding the best research that's available on these topics. Again, these are not going to be medical advice in any way. A lot of these treatments are considered experimental by the FDA, or at least here in the United States. I don't know. Some of the ones like penisin polysulfate are approved where Angela is in Australia, but not necessarily here in the United States. They're used off-label, or some of them, like some of the peptides and some of the medications, are considered, especially the injections, exosomes, stem cells, PRP, considered experimental. But what my goal is to give you information about a potential treatment, maybe good, information showing the good, information showing the bad. You take it to your doctor and ask him or her about that treatment and if it's right for you. Now, back to where we started when I first mentioned some of the stuff we're going to talk about. I want to talk about cortisone shots. That's where I want to start today. By far, the most common treatments offered by orthopedic surgeons and primary care doctors for osteoarthritis. We've done them for years and really for decades to decrease people's pain with osteoarthritis. So in today's live stream, I want to talk about knee arthritis, but what I really say I'm going to talk about applies to really any joint when we talk about cortisone shots for arthritis of any joint. Now, the reason cortisone shots have been used for decades is they do usually relieve pain, or so we think, especially at first. Now, let's be very clear here. Cortisone shots, the steroids, do nothing to help heal or reverse the problem. They don't stop the breakdown of cartilage or bone in the knee. They don't help the bone and cartilage heal to return to the way it was before your knee started to break down. It just makes you feel better. Think of it this way, and I love this analogy. Everybody can sort of picture this. When I was a sports medicine fellow at Washington University in St. Louis, Rick Wright, one of my fellowship attendings, used to tell patients, he explained articular cartilage as the white stuff on the end of a chicken bone. So kind of imagine that. That's what breaks down in arthritis, and then the bone under that does as well. The cortisone shot does not rebuild that. Now, maybe it makes you feel a little bit better for a few weeks, maybe up to 6 months. Now, what we typically see as orthopedic surgeons is that the length of time that those cortisone shots help gradually gets shorter and shorter and shorter. Eventually you get to the point where they don't work at all. And I promise, if you ask some of your friends, you're going to hear the story. Oh, I got a cortisone shot and it worked for 4 months. It was great. And then I got another one. Well, that one helped, but it would only help 2 months. And then this third one really didn't give me much relief at all. Maybe I felt better for a week. And that's what you typically see with cortisone. Then what happens when it gets to where it doesn't help anymore? The orthopedic surgeon, especially when it's a joint replacement specialist, they tell you it's time to do a knee replacement. Having said that, there's been a lot of data published over the last decade, maybe longer than that says cortisone shots may actually be harmful to somebody with osteoarthritis. So that's what I want to talk about today. I want to talk about a study. Normally I'm going to talk about new studies. This one is not new. This was published 5 years ago in 2017, looking at the idea of risk versus benefit for steroid injections for patients with knee osteoarthritis. This is not some obscure medical journal. This is JAMA, the Journal of the American Medical Association. The study was done in Boston at Tufts University Medical Center. Now, it's got a fancy title. I'm going to explain what this is, but the title of the study was called Effect of Intra-Articular Triamcinolone versus Saline on Knee Cartilage Volume and Pain in Patients with Knee Osteoarthritis, a randomized clinical trial. What they did, they did this study to basically figure out the answer to one question. What is the effect, or what are the effects of doing a regular injection of a steroid, in this case triamcinolone? There's a variety of steroids. There's depomedrol, triamcinolone. They're basically more or less the same thing. A steroid's a steroid. It's an anti-inflammatory steroid. You've heard the term NSAIDs, non-steroidal anti-inflammatory drugs. These are not non-steroidal. These are essentially steroidal anti-inflammatory drugs. Anyway, what's the effect of injecting a dose of steroid into the knee every 3 months for 2 years? What effect does that have on knee pain and the articular cartilage in patients with osteoarthritis? So what they did is they did a randomized clinical trial. Took 140 patients, all who had documented knee osteoarthritis and were having pain from it. Now, they start by explaining what osteoarthritis is, and I've done this before on other live shows, and I'll do it again after I explain their version. They say that osteoarthritis is an inflammatory condition, that study after study shows inflammation of the lining, what we call synovitis, along the outside of the joint surrounding the bone and cartilage. And that synovitis has these mononuclear cells and pro-inflammatory mediators that upregulate what are called agrokinases and collagenases, and that multiple studies have shown that inflammation is very common in the knee joints of people with knee osteoarthritis, and it's associated with cartilage damage. That's a fancy way of saying this. I think I can explain it in a little bit more layman's terms. So what most orthopedic surgeons tell people osteoarthritis of the knee is it's a wear and tear problem. The analogy they use is tread on a tire. And everybody can sort of picture that, right? Your tread gets thin. In fact, I've got a tire I'm dealing with now. I'm getting replaced as we speak. But they say the tread's getting worn out, so there's nothing you can do. You just got to replace it with metal and plastic. The problem is, and there may be a little bit of a wear and tear problem involved, but it's much more an inflammation issue. What happens is you get, due to an injury, due to wear and tear for a short period of time, you get these what are called cytokines, these inflammatory cytokines, interleukin 1 beta, interleukin 6, tumor necrosis factor alpha, that go into the joint, inflame it, break down cartilage. But worse than that, then they recruit these enzymes, matrix metalloproteases, that further damage cartilage and bone. That isn't something necessarily to do with wear and tear. Here's the reason I want you to think that there's more to it than just wear and tear, and that it is an inflammation issue, is that one, what do you see when you do a knee replacement? Very, very often, or a hip replacement, doesn't matter what joint. Then you talk to the person, 6 months later, 8 months later, a year later, they're having another joint replaced, then another joint. You never stopped the inflammation going on that's tearing up the joints. Yes, you made that one better, right, by replacing the diseased bone and cartilage with metal and plastic, but that inflammation is still going on rampant throughout the body. The other thing is, if it was just a wear and tear problem, this would be purely a problem of people like marathon runners. And yeah, some marathon runners, long distance runners, do get arthritis of the knee. But so often you're seeing it in people that sit at their desks, sit on their butts all day long. They sit at work all day, then they come home and watch movies all day, and they're overweight and all that. They don't do any activity on their knees, on their hips, and yet they're getting osteoarthritis. So it is not purely a wear and tear problem. The key is stopping that breakdown, stopping those inflammatory cytokines. One of the things that's interesting, and we'll talk about this going forward, is that Advil and Aleve, the non-steroidal anti-inflammatories, and the generics, the ibuprofen, the naproxens, probably don't do that very well either. They may do it short term, but they also seem to block the anti-inflammatory cytokines, interleukin 10, interleukin 13, interleukin 4. So that may be why those aren't terribly helpful. Cortisone steroid shots haven't, to my knowledge, been shown to really stop those inflammatory cytokines either, quite honestly. So the arthritis is largely an inflammation problem, and you've got to stop that inflammation. And we're going to talk in subsequent shows. There's medications like penisin polysulfate that looks very good at doing that. That's in phase 3 trials here in the United States. Apparently it's being fast-tracked by the FDA, which means that the data must look really good. It is legal where Angela is in Australia. They're actually who brought it to us, and that's been very good. Having said that, there's other things out there. There's people looking at things like rapamycin and metformin and semaglutide. We'll talk about all of these as other ways to stop that inflammatory process. Sorry, I went off on a tangent, but I wanted to make sure you understood a little bit about what arthritis was. Back to the study. This was a 2-year double-blinded study looking at the intra-articular injection of a steroid, triamcinolone, versus saline in people with osteoarthritis. What they wanted to look at was cartilage loss, the actual articular cartilage lining and how the composition of that cartilage was, knee pain, and physical function. Everybody was over the age of 45. They all had osteoarthritis. They were randomized into a group either getting steroid injections every 3 months or getting a saline injection, a placebo injection, every 3 months. The researchers doing the injections didn't know who was getting steroid, who was getting saline. The people interpreting it, the patients, nobody knew which group they were in. That's what it means to be a blinded study. Again, it was triamcinolone, 40 milligrams per milliliter. They got 1 milliliter. That was the steroid group. The other group got a milliliter of saline, basically. Here's one thing that's interesting. Neither group got any local anesthetic put in it, lidocaine, marcaine. Very often when you go to an orthopedic surgeon, yes, you get the steroid, but they also put numbing medicine, the marcaine or lidocaine, in it. And there's been some debate about maybe it's the lidocaine or the marcaine that's actually damaging the cartilage. Maybe it does, maybe it doesn't. Here, that's not an issue because they didn't put any of it in either sets of injections. And again, they got either the steroid or the saline every 12 weeks, every 3 months basically, for 2 years. And I'm not going to get into all the numbers and the power intervals and all that. I'm just going to tell you what they found. What they found, intra-articular triamcinolone, basically injecting steroids into the joint, resulted in greater cartilage volume loss than the saline. That is bad. Yeah, it definitely seemed to break down cartilage faster. But more surprisingly, there was no difference in pain between the steroid injection group and the saline group, the placebo group. Adverse events were about the same. The saline group only had 3 adverse events. The steroid group had 5. Not so much a big deal. Again, we cannot blame this on lidocaine or marcaine. That wasn't in either of these studies. The problem is, as you continue to lose cartilage, your rates of getting a total knee replacement go up. So based on this study, the more steroid injections you're going to get, the faster you're going to end up getting a knee replacement. I would say for people that are active and still want to be active, that's not such a great thing. We should not be trying to push joint replacements earlier and earlier in life. So again, randomized trial, 140 patients, all with knee arthritis. Injecting the steroid into the joint had greater cartilage volume loss than just a placebo saline injection, with no difference in pain. I mean, it's pretty straightforward. This is not necessarily a good treatment. And you say, well, it's triamcinolone. Does it apply to Depo-Medrol? I think you could do this study with any steroid and probably get the same result. In their conclusion, it concludes with one sentence, and it says this. Their study says, these findings do not support this treatment for patients with symptomatic knee osteoarthritis. So we need to be rethinking our use of cortisone. Now, here's my thing. For years, and now especially that I do this anti-aging orthopedics, as I call it, I really, really, really try to avoid cortisone shots for almost everybody with arthritis, not just knee arthritis, but any arthritis. I believe, based on this and many other studies that are similar to this, cortisone shots, steroids do far more harm long-term than the benefit, if there's any short-term benefit that people get. Now, maybe you're a little old lady, bone-on-bone arthritis, older male, bone-on-bone arthritis. Maybe that cortisone is not a big deal. You get some pain relief and that knee can't get that much worse anyway. But if you're younger, if you're more active, I really think it's a bad idea. I know a lot of people do it, and this is sort of blasphemy in the orthopedic world. I feel like the data is pretty clear on this. This is not the only study showing similar effects. If this was one of my families with knee arthritis, and actually 2 of my family members do have knee arthritis, I would strongly discourage them from getting a cortisone shot. I personally would never get one if it's me. Yes, Luke, ask away. That is here. If it's about knee arthritis, cortisone shots, feel free. While he's putting in his question, definitely I want to say a couple things. If you like videos like this, I am back doing these every Thursday afternoon, 5 p.m. Eastern Time. We're going to talk a lot more about orthopedic stuff, anti-aging orthopedics, like I was telling you in the beginning, modalities, new medications, peptides, injections, lots of that kind of thing. Or you have friends that do, make sure you subscribe. Ring the bell to be notified when I start a live stream or when I release a new video. Also subscribe to the podcast, Better Than Ever Live, wherever you get your podcasts, Apple, Spotify, Google, Stitcher, anywhere. So if you like that, and then if anybody's typing in a question about the steroid shots, ask those now. Last thing, if you would like to come see me formally as a patient, and I'm getting a lot of requests. The board certification must have helped the word getting out, but I'm getting more than I ever have. I am more than happy to see you. Again, I'm a triple board certified orthopedic surgeon, orthopedic sports medicine specialist, and anti-aging and regenerative medicine specialist. I'd love to meet with you. I see patients here in Charleston, South Carolina, and yes, at least the first visit is done here. There's no way around that, but we can work out ways where we can talk real briefly by video conference, and I tell you kind of how it goes with your first treatment here, and then we can do follow-ups in other places potentially, but that's kind of how it goes. But if you go into the description below, drdavidgeier.com, you'll see that website. Goes to my webpage or to my website, you'll see a work with me button. Drop that down, you'll see contact, fill that out. That gets to me and my assistant, and we will help set that up. All right, so I assume, Helene, you said, what's the solution to control the pain? Yeah, so that's why, to be fair, cortisone has always been done as a painkiller. It doesn't really do anything to treat it, as I was saying, but it does, in theory, control the pain. I've been underwhelmed with it as a pain reliever, but it's probably one of the better things. There are some other things that I think that are probably better, but I don't know that they're as bang, right away you feel better. That's tricky because even things that rebuild the joint potentially, like PRP or stem cells or exosomes, take time to work, 3 months, 6 months or longer. So that's not going to give you the quick pain relief. I have not done this, but I have read literature and I've talked to physicians that feel that injecting BPC 157 into the knee can give some pretty quick pain relief. I don't have experience with that. I will talk about a study soon that looks at that, but that's one thing. I will say, again, not a quick fix like where you get pain relief within a day or two, but the pedersen polysulfate is pretty impressive as a pain reliever for people with arthritis. It can take a while to build up. 4 weeks, 6 weeks, 10, 12 weeks. Sometimes people go longer, but I've seen some and know a lot of people patient-wise that have had pretty remarkable benefit from that. The other, people do injections like the hyaluronic acid injections, Synvisc, Suparts. I've not been terribly impressed with the pain relief. About 2/3 of people get some pain relief, a third don't get any. It's hard to predict who's going to be the 1/3. Doesn't really do anything for the actual problem, but it may have a little bit of a lubricant effect for what that's worth. All right, Luke. Pain management, does steroid injections, I have knee pain, should I be concerned? Well, I mean, should you be concerned? Again, this isn't medical advice. It kind of gets it at what I was saying about I have concerns about steroid injections into joints, into articular cartilage. I don't like them into around tendons, either for a different reason. They tend to weaken tendons, make them more likely to rupture, like around the rotator cuff, patellar tendon, Achilles tendon, things like that. But having said that, for knee, the other issue that makes that a little hard, it depends on what the issue is. But if it's for arthritis, again, it gets back to if you're bone on bone, maybe it doesn't matter that much. If you're not, especially if you're more active, I personally have concerns, and I personally wouldn't get one on me. This is a great question, Christian. I love this. When do you think PRP will begin to be covered by insurance? I don't think it ever will. I really don't. And if you had asked me this before I switched to my practice where I am now, I've been doing this anti-aging orthopedics for about 15 months now, a little over a year, I would have thought eventually. Here's the thing. If you read my book, I don't know where it is, right here, that got published in 2017, That's Gotta Hurt, The Injuries That Changed Sports Forever. I interview the doctor that really made PRP famous in the United States. I tell the story of Hines Ward and how the Pittsburgh Steelers wide receiver tore his MCL, had a grade 2 MCL injury in the AFC Championship game before the 2009 Super Bowl. And yet he wanted to play in the Super Bowl 2 weeks later. And Dr. Bradley did 3 PRP injections to get that MCL to heal. And no big deal. Nobody really knew anything about it. But somehow, and I interviewed her in the book too, Andrea Kramer, the NBC sideline reporter at the time, heard about it, asked Hines Ward. He admitted it. So right before the game starts, they do the Star Spangled Banner. They do the flyovers, all that kind of stuff. 90 million people watching this. She does a sideline report saying that Hines Ward's going to play because he underwent PRP treatments, and she briefly explained what it was. Of course, nobody had ever heard of this in the lay public. About 2 weeks later, there's a front page story in the New York Times. Not front page of the sports section, front page of the entire New York Times newspaper about how the demand for PRP had exploded since Andrea Kramer reported it at the beginning of the Super Bowl. And then that led to this, everybody wanting it, insurance companies weren't going to pay for it. 2009, we're at the end of 2022, and it's still considered experimental, and insurance companies, the FDA considers it experimental, insurance companies don't pay for it. And it's really frustrating because for so many problems, PRP's been shown to help. Yes, there's studies that show that it isn't helpful for everything, but the problem is PRP research, and this is true a little bit with stem cells, and it's going to be true with exosomes, maybe to a lesser extent peptides. The problem is there's so many variables at play with PRP. Everybody makes different amounts of platelets in their body, so then when you concentrate it, some people have more platelets than others. Some PRP systems keep the white blood cells. Some PRP systems get rid of the white blood cells. All potentially potentially having a different effect. Some use an anticoagulant in the syringe, some don't. There's a lot of variability in the studies that makes those studies very hard to compare. But there are very, very good studies. I just did the first year of my recertification from my orthopedic surgery and sports medicine boards, and one of the articles that we had to read was on and take get quizzed on was on PRP, and I guess it was arthritis. I don't remember now. This is like 6 months ago. But it was very positive. The effects were very good in a top level. I think it was Journal of Bone and Joint Disease, the top journal in all of orthopedics. So I don't know. If it's not approved now, I don't see what changes to make that approved. Jim Bradley, again, if you check out the book, you'll hear me write what he says, that part of the reason it's not approved is that doctors doing it charge way too much for it, and that's what's keeping the insurance companies from paying for it. I don't think that's true. The FDA is going to have to decide it's not experimental, or the insurance companies aren't going to do it. But having said that, there is something to be said for maybe that is part of the problem. So for what that's worth. All right. I don't see any other questions. I am very, 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 very glad to be back. I am thrilled that you had questions and hopefully found this interesting. We've got a lot of topics like this, especially about, again, this world of anti-aging orthopedics that I want to bring to you. So every Thursday, make sure you subscribe, ring the bell to be notified, but plan on joining us every Thursday afternoon, 5 p.m. Eastern Time. If you miss it, definitely subscribe to the Better Than Ever Live podcast and get it there. Very, very thankful that you're here. If you have other orthopedic questions, join us tomorrow for Ask Dr. Geier Live, and I will